This
Start.
conference will now be recorded.
Yeah. So I'll share the screen with all of you so that you're able to see the presentation. So everybody on mute mode, please. Everybody on mute mode. I can see that there's someone who is unmute. Yeah. Okay. So first of all, if there are people who have just cleared part one, congratulations and welcome to part two. Now this is where the real journey of MRCOG begins. And let's start with the real OBGY guidelines. Okay, just wait for the real part of MRCOG to strike you now. Because part two is all about the nice guidelines, the green top guidelines, and the TOG articles, everything that you have been listening or you have been hearing in CMEs or conferences. Now, this is the time to actually read that and conquer those guidelines and give exam on that and be the member of the college, because this is the material which is again going to help you for your part 3. There's nothing apart from the syllabus of part 2 that is different in part 3. So exactly the same syllabus, it's only the application of the syllabus of part 2 that is there for part 3. So it is only communication skills, how you communicate the guidelines. So it is very important to understand the guidelines that you're reading. Okay. And that you will come to know only when you read the guideline. So this part 2, of course, requires much more preparation than part 1, because I understand that part 1 in itself is basic sciences, and it must have taken you back to your MBBS days where you had studied anatomy, physiology, biochemistry, right? And much of it was related to gynae. But this is completely a different format. You'll be having something called as EMQs here, which is different from the exam that you have given for your part 1. I'll tell you what it is. Okay, so this is the basic syllabus that you should be doing for your part 2. That is the green top guidelines, the nice guidelines, the best practice papers. Then you should be knowing the consent advices, then the scientific impact papers, BASH guidelines, the good practice papers, ESHRE guidelines, the embrace guidelines, which come up every year, and they tell you about the maternal mortality rate, and the FSRH guidelines. Well, you think this is enough? You still have TOGs left, and TOGs are actually, they have a very high volume. They make a very big volume for part 2, because they keep on coming every year and 4 times in a year. So the moment you feel that you have done the last article of the talk and you're about to give your exam, the uh, another talk comes up. So it comes every 3 months, 4 times in a year. So every now and then it gets updated. But fortunately, because the papers get set at least 6 months before the exam, so we expect that the talk that gets released at the end of just near the exam is generally not included in the paper. Okay, so you have to remain updated until the talk which comes at least 6 months before the exam. Okay, so and you should read at least 5 years of talks, okay, from your exam, from the date of your exam. So if when you're giving it in 2023, you should be knowing at least from 2018 onwards. Strategy, which is now called as strategy, when we were used to give which is now called as e-learning, sorry. When we used to give our exam, it was called as strategy, and that is why we are more fond of calling it strategy, because e-learning somehow becomes very tedious and sometimes becomes very confusing. So this is available on the website. You need to pay. You have to be the subscriber of strategies. Nowadays they have changed it that those who are the associate members can have a subscription for strategy free. So you have to pay for being associate member, and the same subscription can be used for e-learning for trainees, right? So therein you will get all the material. They again, strategy or e-learning also has question bank, which is again a very important thing, and it keeps on coming every now and then in part 2 exam, right? So I would suggest that if you're investing your money, and if you have very little money left for investing into courses or into the preparation, then, or books, please put your money into subscription of strategy, right? That is the best thing to do, because any which ways you're going to require self study. You're going to require at least one course that will keep you motivated, that will keep you scheduled, and will keep you updated. And strategy will give you extra edge, because you keep on solving the questions and you get an idea of what type of questions might be asked. Again, it is very, very vast. If you read strategy and if you're able to finish it, then believe me, if there's one tip that I would want to give you that I remembered just now, that whenever you're reading anything apart from the guidelines, start making your own notes, because there's no chance that you're going to come back again to the same thing and will be able to recollect anything from that, or will be able to make notes for the second time, because the portion is so vast that if you finish the whole portion at least in one go before the exam, even that is considered to be uh, heaven, because that's not possible. It is, the portion is so vast, new guidelines keep on coming every now and then, new TOG articles keep on coming up every now and then, so it is difficult to keep up with the portion. So I would suggest that from the very first day you start with uh, your preparation, which is apart from the guidelines. I would suggest that not to make notes from the guidelines. The reason why I see, most of you must be knowing that there are people who actually provide notes for the guidelines, but it is always better to keep the whole guideline in front of you, because you never know which sentence becomes your question. The whole of the guideline, the nice guideline and the green top guidelines, both the guidelines should be at the tip of your tongue. They should be at the tip of your tongue. Remember that. Apart from that, TOG articles, strategy, important points you should be knowing from that. So the moment you start reading your talk, the moment you start reading your strategy, you have to make notes. Start making notes. And next time you are not reading from the from talks or from the strategy, you are reading from your own notes. Okay, because maximum is you'll get 2 to 3 revisions in 6 months to 1 year's time, if that is the time you're keeping for your part 2 exam, right? Now, this one was actually prepared for the September candidates, because this is the only thing that is available on the website right now. They have not given up the dates of January exam as yet, though we are expecting the January candidates to have their schedule in next couple of months. But until it comes up on the website, we actually cannot say when is the exam, right? But it is better to be prepared for at least 6 months before the exam. So you should start your preparation right now if you're targeting January exam. Now this is the booking process. You have already done it for your part 1, so it's unnecessary and I need not go into details of it. You know how it is. You have to express your interest on the dates that have been suggested, and then you have to book you get a booking token which was not given, which was again changed last time. So it keeps on changing every now and then. You just have to keep up with the mails that they keep on sending you so that you know what changes they have made every time. And then accordingly you will get your booking seat. When the booking window opens, you have to book your seat and book your seat accordingly, according to your convenience, right? So the exam is going to be exactly like you gave your part one. So it is again going to be a computer based exam, right? So I was telling you this is different exam, not same as part one. The reason is there are two papers, paper one and paper two, right? Paper 1 will have 50 SBAs and 50 EMQs. Now, SBAs, you all know what they are. SBAs is one question and five options, and you have to choose one of them, right? There are 50 EMQs. EMQs are where you have, say, around 10 to 15 options are there, and there are some 3 to 4 questions related to those options. The difference is that the option can be repeated. For like, option A can be answer of two of the questions, okay? And the reason why EMQs are difficult is because EMQs are completely based on application of guidelines. It is not based on memorizing like SBAs. Most of the SBAs are recalls. For even for part 2, you would realize that you will be able to solve SBAs. If you have done your recalls, you will be able to finish them within first hour, right? And you'll get a lot of time for EMQs, and that is very, very, very important. The reason is every year they put some questions which are new, and these questions are difficult to solve. So you need time to solve your EMQs. And that is why all the recalls should be completely solved by you before you sit your part 2 exam, right? So that you don't waste your money in memorizing the answers for SBAs, right? Same goes for paper 2. Paper 2 again is of 3 hours, has got 50 SBAs and 50 EMQs. Now RCOG suggests that you should invest 110 minutes into EMQs and 70 minutes into SBAs, which I said happens with anyone who has read the recalls and has who is done with the studies will solve SBAs within first 60 minutes of starting of the paper. Okay. Now this is why to go for a course for part 2. It is very, very important that you follow a schedule for part 2, because as I said, part 2 is very vast and it is very easy to get lost into one module. If you start if you start with one module and if you want to finish the whole module, you need to have specific time allotted for that, because it is never going to be enough, except for some small modules like subfertility, oncology, urogynecology, which can get over within 3 to 4 days if you keep your schedule very strict, right? Otherwise, if you start with maternal medicine, ANC, I'm sure, or labor and delivery, you are never going to get out of them because they are very vast. They are never going to get over. So it is always better to take a course to keep a track of whether you're going, whether whatever you're doing is right or not, right? Also, when you study with friends, when you have a group study, you remain motivated, and then you even can discuss your things in the group, right? So this you all have noticed, because there are many groups running for in the same way, right? Now for MRCOG part 2, we have 4 mentors. Now, before I used to take it alone, but now we have got mentors who will be taking the modules, and they'll one mentor will take 2 modules, one from Gynae and one from Ops. Okay, so we have got Dr. Nusrat and Dr. Deepa, who are actually working in NHS, so they know the whole system there, and they can help you with the clinical governance part. They can help you with the labor and delivery part, wherein we don't know how it works and the answers become difficult, right? We know that the answers become difficult when they ask you where to go to complain if there is bullying, right? If there is a problem with the patient, if the patient has to complain, where to go? How many of us know about PALS? Nobody knows. So unless you get someone who is working in NHS and who gives the real-time idea of how PALS work, then you can easily write the answers, right? Though everything comes up to you when you study in a group. When we have a mentor who actually works there, it gives a different touch, and we can make use of them in the course, part 2 as well as for part 3. We have Dr. Deepa working in NHS as ST3. Dr. Nusrat has just joined there. Dr. Jia is working in Dubai and she is a subspecialist. Dr. Rupal is going to help us with the questions every day, and she is a consultant working in Gujarat, India. Dr. Varsha Priyadarshini has just passed her part 3, and she is a bright candidate, and she has got a lot of applause from the candidates of my previous batch, because she has taken her modules were really, like, they got benefited from the modules and they were taken in depth. So this is the reason why we have expanded, so that everyone who is good in that subject is going to take your modules, and you can actually keep on asking them questions every now and then, so that all of us can be of help to you. Now remember, this course, you'll be given everything apart from this study material, like the books which are there in almost all the Telegram groups. Along with that, you'll be given written notes, you'll be given audios, you'll be given videos as well. And you'll be given the whole syllabus along with strategy. Okay, so if by some chance some of you have not subscribed strategy, then most of the things will be provided by the course. I would still suggest that you take your own strategy, because there is a chance that they may update strategy, and most maybe that part might not be included in the material that is available in the course. So it is always better to have your own strategy. Along with that, the strategy things that will be provided from the course will be given to you as notes, so you actually don't have to go into details of all the lessons of, like, say for example, maternal medicine. There are hundreds of uh, chapters there, right? So you'll be having blood disorders, you'll be having gastrointestinal problems, hepatic problems, kidney problems. So how many chapters you're going to read? So you'll be given a comprehensive notes regarding the same, and you will have to just read the important things. My own handwritten notes are available, which will be available to you in this course. So this will reduce the time, and the most important thing is to reduce the time that you put in for your part 2. So that is the most important thing for part 2, is to get time for revision before the exam. I'll tell you one more important thing here, is that many of the candidates who actually studied very well and scored very high in their whole course and did not revise in the last 15 days for any reason. Say for example, they did not get leave from their colleges, or they had some ceremony at home, or they were ill for some reason, they could not do well in the exams. Whereas the candidates, I have been with the candidates who never attended sincerely, who were not present many of the times, and or they did not get time to study for the whole of the course, but sat and revised in the last 15 days, actually cleared in the first attempt. So last 15 days revision is very, very important, and you should get that 15 days. Believe me, with the syllabus that you have got, it is very difficult to get those 15 days also. So keep yourself very much scheduled. So that is the most important tip that I would give you, and please keep it in mind that you have to be on the track all the time. Okay, so you'll be given weekly sessions, you'll be having practice group, you'll be given questions, you'll be given recalls. Also, you'll be told about the tips and tricks. Now, there are ways to remember things. When you have such a mountain of portion, then you have to find smart ways to remember things. So you'll be given tips on how to remember the numbers. You'll be given tips on how to remember the your most of the times the um question banks that you'll be given, we'll be telling you on how to remember the answers for particular questions, right? So most of the times you will be seeing that the same question gets repeated, but we'll be telling you on how to understand that this question is different. So you'll be given uh, extra tips. Like for example, we'll be giving you uh, the same question, and we'll be changing one word there, and how the answer changes. So many googly questions will be asked, and this is a very important thing that we have started from the last batch, and it was very much appreciated by the candidates, right? So there are few things that you'll come to know only when you join the course. Of course, notes and summaries, as I said, again, MRCG Goal is very much known for minimum charges. We don't charge 50,000, 80,000. And the reason is because when I was giving my exam, I couldn't take any of the course. And, and neither the courses were not available either. But all the courses that were available were either from UK or from Dubai. There was nobody from India who were taking the courses. And all of them used to cost above 50,000, and not everybody can afford that. So we are starting with a very minimum charge of 20,000 uh, uh, for the whole course, including the mock test and the test series. You'll be having test series along with the live sessions. For today, because we are starting from tomorrow onwards, only for the last 24 hours, we have reduced the charges by 2,000, and only those who will be paying in this 24 hours will have an extra benefit of getting the whole course at rupees 18,000, right? So if at all you want to join, please let me know, message me on Telegram or on WhatsApp if you have my number. Okay, so this is wishing you all the best. And let's go to the TOG article. This is the recent one. And the reason why I have taken up this TOG article is because this TOG article is very big. It's around some 6 to 7 pages, and you spend at least 1 hour if you are a fast reader reading this whole TOG article. So I'll tell you a trick on how to remember and finish your talks within 5 minutes. So when you have revisions, you have to start making notes like this, and within 5 minutes in the last revision, you should be able to finish the whole talk, right? So this is the talk that has appeared in April 2022. Impact of intrauterine environment on future reproductive and metabolic health. So we know that when the baby is in the uterus, the fetus actually, whatever the environment the fetus gets, that is how the whole, it changes the metabolic structure, the genetics of the baby, and mostly that is how the whole life of the baby changes according to the intrauterine environment. So that is the whole gist of this talk articles. That's it, right? The reason why I've taken this talk article is how you can skip the maximum thing and still uh, revise the whole of the important things, right? So basically, this is about, they are telling that maternal obesity, GDM, and again advanced maternal age. All of these factors, they affect the baby's health. Important things to remember: what 50% of women of the reproductive age are overweight and they're obese, and 1 in 5 are obese during pregnancy. So your SBA becomes clear here. They'll ask you SBA: 50% of women of reproductive age are overweight or obese. How many? 50. How many of them are obese during pregnancy? 1 in 5, right? Moreover, 1 in 20 women in UK are diagnosed with GDM, and approximately 1 in 10 is a smoker during pregnancy. Another, so you got 3 SBAs from this one particular slide, right? So you have to write the notes immediately. Okay. So during the pre-implantation phase, the recent advances have shown that development outside of the female reproductive tract reduces the mitochondrial DNA copy number, and that is one of the earliest adopted proxies of embryo quality. With over 7 million children worldwide having been conceived to death using various ART techniques, up to 6% of European babies are conceived using ART. These are the findings of widespread interest and significance. So you have to remember 7 million and 6%. 7 million worldwide, 6% in Europe. Again, maternal diet, maternal weight gain, they all influence the fetal growth, and it affects the health of the child in the later life as well. Now, children who were in the womb prior to maternal surgery, they were significantly heavier by mid-childhood than their siblings born after the weight loss surgery. Now, those women who were obese and they had underwent this weight loss surgery, so they have said that this was the difference that they could find, that the children who were in the womb prior to that, they were heavier, so they had all the influence of the mother's weight, and after the weight loss surgery, the children who were born after that, they did not have that much of weight and did not, like, they were much healthier as compared to their siblings. Now, this important catch-up growth. Okay, what is this catch-up growth? A commonly observed pattern of perinatal growth that predicts the later adverse health outcomes in both human studies and animal models is called the catch-up growth, which describes the fetal growth restriction followed by accelerated early postnatal growth. So just to catch up the growth, there is accelerated early postnatal growth, right? Done. Fetal growth restriction can lead to reduced satiety and blunted response to leptin. This is important, ultimately resulting in appetite dysregulation and obesity. Now, this catch-up growth is often viewed as a healthy phenomenon by the parents, because we feel that the baby is growing very fast, and the health workers, we all feel that this is a healthy phenomenon. However, some evidence suggests that children exhibiting this growth pattern are at increased risk of various adverse metabolic outcomes, including diabetes and obesity, right? Because they keep on growing very fast, there is a high chance that they may have metabolic disorders which may cause diabetes and obesity. Now, this is a useful adaptation if the postnatal environment is also likely to be resource poor and may confer a survival advantage to the offspring who might otherwise struggle to thrive. However, when there is a mismatch between resource poor intrauterine environment and calorie replete postnatal environment, the newborn baby is poorly adapted and may be at risk of later pathological complications of excess energy and calorie intake. Now, again, whatever changes or whatever environment the fetus has during in the intrauterine life, it again affects the epigenetics. What is epigenetics? It is the process of varying gene expression through changing parameters other than the genetic code itself Although the complete genetic code for any individual is fixed at the time of conception, expression of individual genes varies enormously throughout life and in different cells of tissues. So, this epigenetic modifications to DNA allow flexible gene expression, and hence it will alter the phenotype. Understood? So, they've said that though the genetics they get fixed, most of the time the how they express it all depends on the intrauterine environment of the fetus. Again, this is very important example that they have given, which might appear as a SBA if they are very much interested into this article. That is methylation of DNA at specific sites in the genome that alter the promoter or the repressor activity of the individual genes. Modification of the histones, which are responsible for packaging of the DNA into the nucleosomes, can also occur through acetylation and render the genes more or less amenable to expression. So, this is a different epigenetic modification that may appear, that is methylation of DNA at specific site in the genome. Again, they have said that it can alter the tissue and the organ structure, the intrauterine environment. So during the organogenesis, the brain, of course, is protected at the expense of other organs, right? So it will get more of the blood supply, and fetal muscle and adipose tissue, they are highly sensitive to the metabolic milieu, for example hypoxia. So they are the most sensitive one for hypoxia, like muscles and the adipose tissue. This is common in severely growth restricted infants, leading to hypercatecholaminemia and reduced oxidative glucose metabolism, right? So what happens is whenever there is hypoxia, the brain will get protected, as we all know, and the muscles and the adipose tissue, uh, they'll suffer, right? And this will result in the fetal glucose utilization is prioritized in the neural tissue at the expense of the muscle to free the resources for the neural development. So this is basically how things can change, because if there is hypoxia in the intrauterine area, then it can change the cause oxidative stress there and can affect the organogenesis of the fetus, right? Again, there can be cellular aging if there is change in the intrauterine environment. What they have said is that adverse conditions in utero predispose towards early aging of the cells and tissues and disrupt the normal protections against the premature aging. So, all as cells face accumulating stress during life, the telomeres will gradually shorten. With each cell division, around 30 to 150 base pairs are lost from each telomere, although DNA repair mechanisms and activity of the telomerase can help to compensate for some loss. So, they say that whenever there are adverse conditions, again, there's some of the base pairs, they get lost from the telomere and can cause the cellular aging. So this is how it affects the metabolism and affects the further life of the baby. And when the telomeres reach a critically short length, this triggers the cellular senescence. The cells and the tissues that accumulate excess the damage early in life, and this exposure to a suboptimal intrauterine environment, this will cause more aging, and it will cause diabetes, it may cause obesity, and may cause pathological phenotypes earlier in the adult life, right? Again, it can affect the programming of the HPA axis, the intrauterine environment. So in humans, if there is maternal obesity, it is associated with alterations in the salivary cortisol in the cohort followed by adulthood, suggesting that HPA axis activity may be programmed in utero. Again, it can affect the placenta. Placenta is the key determining the fetal outcome, and both in short and long term, maternal environmental factors can influence the placental phenotype, including the size and the vascularity. Right. So both the things can get affected, and future, again, in future obesity, the intrauterine environment has a key role, right? So the link between the human birth weight and the future obesity is well established, with the recent study indicating that every kilogram increase in the birth weight, there is a corresponding 50% increase in the risk of being overweight by the mid childhood. Again, becomes your SBA with every kilogram increase in the birth weight. So if 3 kg baby becomes 4 kg, with every kilogram increase, there is a 50% chance that this baby is going to be overweight by mid childhood, right? Mesenchymal stem cells derived from the umbilical cord blood of humans show greater tendency to differentiate into adipocytes and myocytes in the cord blood derived from obese pregnancies, and this is correlated with increased adipose tissues, which is measured in the neonates after 72 hours, so as early as 72 hours in life. Maternal obesity may also get affected, um, or may also directly affect the epigenetic regulation. We have seen that how it can affect the genetics. It can affect the genetics. It can affect the chances of getting obese. It can affect the HPA axis, right? Again, it is not that only maternal obesity is affecting or maternal hypoxia is affecting. Maternal undernutrition is also going to affect the fetus, and it is going to affect the life of the baby, the like the later life of the baby, the metabolism of the baby. So again, they have said that maternal smoking has also been an important influencer. And what is the dose dependent association up to 15 cigarettes daily is going to cause problems. That is, it is going to cause long term obesity risk. 15 cigarettes daily. While complete cessation is ideal, it is important that you tell the patient to reduce, at least reduce smoking. The mechanism by which maternal smoking increases the obesity in fetus is unclear, but recent work has shown that there is alteration in the DNA methylation in the cord blood with smoking, and that causes increased risk of obesity in the offspring in the smoking mothers. Okay, so smoking mothers, hypoxic mothers, mothers who have are undernourished, mothers who have obese, all the types of environment that any environment that the mother gives is going to affect the metabolic, uh, the genetics, and the HPA axis. Like everything, it can change in the baby, how the phenotypically, genotypically also. Again, mothers who have got type 2 diabetes, again there is increased chance that the babies will also be at risk of metabolic disorders further. Though we consider this to be multifactorial, this is a very important thing to affect the baby's growth further after delivery. Again, it can affect the appetite and behavioral regulation. We have seen how it affects the HPA axis, right? Again, it can be responsible. The maternal environment can cause dyslipidemia. So all these things are actually, they can come up as SBA, that how, what it affects. So they can write HPA axis, they can write dyslipidemia or the lipids, they can write obesity, right? So it affects at every other level, even the epigenetics as well. Okay. During pregnancy, obese mothers usually have high circulating availability of fatty acids, and these easily cross the placenta. So there's accumulation of fatty acids in infants born to obese mother with GDM, and it can be demonstrated via the MRI scans. Now this is important. MRI scans show 70% increase in hepatic obesity in infants born to obese mothers with GDM compared with the control. So there is 70% increase in the hepatic obesity with the obese mothers, right? Again, this can become your SBA, because remember, every percent in part 2 is important. So every time you see a number, you have to write it down. Okay, again, it increases the chances of fatty liver in pregnancy, increase in the obesity, right? Again, evidence of fetal developmental programming of fetal reproductive capacity. So during the mid-trimester fetal development, the human ovary can already produce androgenic response to the changes in the intrauterine environment, especially in response to the maternal hyperinsulinemia. Now, there is evidence that suggests that there is increase in the testosterone levels in the cord bloods of the female infants born to mothers who themselves have PCOS. Early exposure to altered steroid milieu may therefore be an important contributing factor to the risk of developing PCOS, and again it can cause unovulatory infertility in the later life. So those who have got PCOS, again there is a chance that the babies can have the same thing, and that is why we say that sometimes some things are inherited, right? So this is how they have said that the intrauterine environment can affect the it can also affect the adult oviduct, the energy production in the adult oviduct, right? And can also cause infertility. So if the mother has got infertility or there is an environment that can affect the fertility, it may affect the fertility status of the baby later on in life, because it can affect the ovaries, how the ovaries function. It can affect how the oviduct functions. And that is why the focus needs to be on the preconception care. Okay. So aspirin, they have said, may also be helpful in maximizing the placental function where the risk factors are present. Again, you should be optimizing the maternal weight. There should be encouraging of the physical activity, improving the lipid profile, and smoking cessation prior to pregnancies. All this will put the mother into a very uh, uh, required state where the baby is not going to get affected much, and the baby is not going to have any metabolic disorder. So this is what we want. We want a healthy mother and a healthy baby. So these are the two diagrams that you'll see in TOG. So the same thing, that it can alter the tissue organ structure, it can affect the epigenetics, it can affect the maternal obesity, uh, gestational diabetes, maternal age, smoking, chronic fetal hypoxia. All these things are going to affect the baby, right? And what are the later life impacts? The baby can have obesity, can have diabetes, can have cardiovascular problems, dyslipidemia, PCOS, pubertal timing can get changed, as we have seen that there can be chances of infertility also. There can be decreased ovarian reserve. So all these things are going to affect the the baby in the later life. Okay, so they have given you what is to be done. So what is the correct management of each of them? So maternal factor, if the mother has got low body mass or the mother is underweight, then there is a possible risk that the offspring will have obesity and will have hypertension. Then what is the management? Correction of the nutrition deficiencies, right? Then advising for the healthy weight maintenance, and sensitive exploration of whether the mother is having any other stress or any other mental health issue. Okay, so all these three things you should be able to achieve. This again becomes important for your part 3 um, exam, right, wherein you have to take care of all these things when you're seeing a mother who is underweight. If you see a mother who is obese, then there is chance that the baby can be obese, have dyslipidemia, can have cardiovascular problems or type 2 diabetes. So you'll be suggesting her to go for weight loss. You'll be telling her to encourage physical activities and aspirin during pregnancy. If she's smoking, again, the baby can have obesity, hypertension, insulin resistance. You have to tell her to go for smoking cessation and aspirin during pregnancy. If there is chronic fetal hypoxia, then there are chances of obesity, cardiovascular problems, and the baby will require, the mother will require close monitoring of pregnancy, and including Dopplers, and you should be knowing the exact time of delivery, right? Because hypoxia should not cause IUFD. There is a very high chance there, so you should be knowing the time of delivery just before the Dopplers become very bad, right? Uh, Gestational diabetes, the babies can have obesity, impaired glucose tolerance, type 2 diabetes, and of course, you should be giving the lifestyle changes to the mother. You should be telling her to exercise, to have a proper diet chart, be on either metformin or insulin, depending upon the type of diabetes that she has, and advise her regarding continuing the maternal diabetes screening program, right? Which you'll come to know once you enter into your part two, right? So that was your talk, and I think we finished the talk within 10-15 minutes. So this is how it should be. The next time you read the talk, you should be knowing the exact points: 1 in 10, 1 in 20, 1 in 5, all these 5 things, and what are the how to go about it, right? So what are the treatments that are available? This was a very easy thing because we all know that the intrauterine environment is going to affect the baby. This was a very easy talk. This was just an example on how to read your talk and finish it and not to go back to it again. Okay. So this was a session for you today, everyone. For the mini mock, please message me, and I'll send you the link by tonight itself. You have to finish that 25 questions there. You have to finish your test, and I'll be giving you the scores. Okay. So it'll be a computer-based exam, just like your exam, and you have to finish the test there itself. So I'll send you the links. You have to message me or send me your WhatsApp numbers so that I can send you the link there also. If any one of you has any doubt, please let me know. Any doubts as of now for part 2 related to part 2? Okay. So all of you, Dr. Monicum, do you want to go uh, for the this test mini mock? Because I think you're appearing for part 3, isn't it? Okay, I'll send all of you. Doesn't matter. I can see many similar faces. Anusha, Suvarna, everybody. Okay.
Thank you, ma'am.
Sorry? Sorry. Please come up again.
Thank you, ma'am. Thank you, ma'am. I thank you, ma'am.
No, Dr. Monica, we can see you in all the courses. So I was like, we even had this. You,
Ma'am, I also want to attend, ma'am. Thank you, ma'am.
who is that? Your name, please. I'll be sending you all of you. Please message me either on Telegram or on WhatsApp so that I can send you links
Hello,
personally.
Preeti ma'am.
Yeah. Yes,
Hi ma'am,
Anusha.
this is Anusha. Yeah, I was asking whether Pass MRCG subscription is needed, ma'am.
No. Why do you want to go for Pass MRCOG? Most of the
Okay,
questions are available. No, don't go for any other. See, there are many online question banks. So how many you're going to go for subscribe and you'll waste your time. So most of them will be available on the in your groups as well. So don't worry. We have many of them. So we'll be providing that for you, like that free for you. Don't worry. Most
okay,
important
ma'am.
is go
And
for strategies and see the
ma'am,
question.
also I wanted to ask you. Sorry, ma'am. I'm sorry for interrupting. Yes, now continue.
No. Tell me. Anusha, tell me.
Ma'am, I was asking regarding the CPD questions. So are they important, which are given at the end of the TOG article and FSRH guidelines? And where can we find the answers from? I mean, they're not very straightforward that we can easily find the answers from the TOG article. So
Hmm.
how to go about with them, ma'am?
So CPD questions we used to keep at the end, I remember. And many of the nowadays there are some CPD questions which come up as true and false. So of course they are of no use to you. Just in case you have time and you have read the article and you want to finish or you want to see whether you understand the article, you can go for true and false. There are few CPD questions which came up as SBAs. It is very important to solve those questions which come in your format, in the format of SBA and EMQs. But in the last two TOG articles, I could see that most of the CPD questions were in the true and false format. So I don't know why they have changed the strategy. A few years back, we had used to have this SBA EMQ format. Whatever is there in SBA EMQ format, go for that only. Okay, even if you
Okay.
have TOG articles, uh, and if they are asked in the same in SBA format, you can easily solve the question if you have understood the TOG.
Ma'am,
So
also I wanted to know if also, yes, ma'am.
go for CPD only if you have time.
Okay, ma'am.
Otherwise,
Ma'am,
you have
what about the book, ma'am? Because the current questions which they are giving in RCH exam, they are not many are from the books that we are supposed to read.
from
So,
nowhere.
um,
I know most of them are new. Most of them are new and they come from nowhere. So they are made by the examiners. So these questions are difficult for everyone. And that is where you'll be tested. You'll be tested on the questions that are already coming up in the exam every now and then. So you should be thorough with your recalls. If you have done your practice very well and you have understood the guideline, you will also get answers of most of the questions that they ask. So that is what is expected because they don't give you the answers. RCOG never gives answers of the questions that were asked. So we can only guess what was the right answer, right? Also, that
okay,
is from the people who passed. So we can only guess that people who passed gave right answers to the questions that were asked. So there's nobody on earth except for the examiner who has written the question can tell you what is the right answer. So in that case, what is important is what was the question. If they have asked you obesity, revolve around obesity. See what are the talks that are important, what is the guideline that is important related to obesity, and you should be thorough with obesity. Like, mental awareness was a very, very important thing there. And if you have not read mental awareness, then you lose many of your marks. So see that your nice guideline related to mental health is thorough, and you should know when to give lithium, when to stop lithium. So they can ask you anything related to that. If it is not there in the books, even then it is okay, but at least you should be thorough with the things that are asked related to the topic which they are interested in, right?
yes, ma'am.
Yeah,
And
so that is
which book do you recommend doing, ma'am? Andrew Sizer, Justin Conge, and anything else?
all the books are important. There's no book that is not important. All the question banks. In fact, we used to find out books from 20 years back and try and solve the questions from there also. The more the questions you solve, the more easy it becomes for you to pass your part two. Again, this is another advice that I give to all the candidates is know all theory, know all SBA AMQs, because I've seen that many of you have retrospective studying, like you solve SBA AMQs first and then you read theory. That is also wrong. Reading all theory together and then keeping time for SBS and EMQs before the exam is also wrong. Half of your time, say for example, you have kept one day for maternal obesity guideline. You should finish your guideline within half day, and rest of the time you should be able to solve the EMQs and SBAs related to that guideline. If you can't find the SBAs and EMQs related to that guideline because there are many books, it is difficult, you'll finish time. At least keep 2 hours for solving the questions generally, because that is how you will keep yourself motivated. Okay, so that is a very important thing. You remember that before the exam, because it is difficult to finish the portion, plus it is difficult to finish the SBA MQ books. So how to maintain the balance? This is the way you can maintain the balance. Start it from the very first day, so that you remember everything. Then also the interest remains. Whatever you have read, whether you can give the right answers. And the best, see, nobody can tell you how you can pass. You can only study best. So the best method that you can go for, and it comes it's by its own. If you have given your best, it has to come.
Okay, ma'am. Thank you so much.
Yeah. Okay, so I'll send you the links by 12. By 12, I'll send you, or maximum by tomorrow morning. You have to solve the mini mock test and let us see where we all stand. Okay? Anyone who wants to go for the course can message me directly. Thank you very much. Good night, everyone.